In this lecture, we're going to review some of the basic fundamentals when it comes to the initial part of working with clients, and that's the interview and screening process. And so in this first part of Unit 3, we're going to take a look at some of the factors that require important consideration prior to working with a patient or client. And the first reason that we'll discuss here are the reasons for the referral to the clinical exercise physiologist. And then at that point, the clinical exercise physiologist will engage in what we will review as the general interview, which will include the collection of demographic information, evaluating the history of the present illness, becoming aware of any current medications, allergies that the patient or client may have, a review of the past medical history, family history, and the social history as it relates to certain lifestyle behaviors will help to form an overall picture of that patient and client so that the testing and prescription of exercise can be optimized. When we start with the reasons for referral, the clinical exercise physiologist should have a good idea of why that patient or client has been referred. And there are many reasons, but some of the reasons include the intention to improve exercise or to simply physical activity tolerance to improve activities of daily living, improving physical capacity, improving strength, and ultimately improving overall function. As I indicated, the goal here is to eventually enhance the patient or client's ability to carry out successfully those activities of daily living. This is also an important or a critical point at which the clinical exercise physiologist can develop an understanding of how well the patient is aware of their current condition. And the general interview will begin essentially with a collection of demographic information. And part of that demographic information will include an understanding of what are referred to as the non-modifiable risk factors for cardiovascular, pulmonary, or musculoskeletal disease. One such non-modifiable factor is age. It's well known that as people age beyond a certain point, there is going to be a natural decrease in aerobic capacity, and there will be an increased risk for developing various diseases. One such example is the development of osteoarthritis. This is related to age, but age does not always result in osteoarthritis development, but it is considered to be a risk factor. The sex of the patient or client is also statistically related to the development of certain diseases into older age. One such example is that rheumatoid arthritis is more prevalent among females than males. And the clinical exercise physiologist should also gain some understanding of the socioeconomic status of the patient or client. Getting a review of the present illness, this relates back to the reasons that eventually led to the referral. What were the chief complaints of the patient that sought medical attention? And so at this point, identifying what those chief complaints were, the signs and symptoms, as well as and how that relates to the present illness will help to guide the development of an exercise program. And so it's important also to understand how to make certain identifications of those signs and symptoms. As the patient or client is recounting their chief complaint and their challenges with daily activities, it's important that the clinical exercise physiologist minimizes verbal interruptions. So uh, allowing the patient or client to complete their sentences, waiting for a break in their statements is a good time to jump in and ask further questions. It's also recommended that the clinical exercise physiologist avoid the use of excessive medical terminology, as the vast majority of the public will not have an academic background in this particular field. So presenting the information in lay terms is going to be advantageous. One approach to characterizing symptoms is defined by a technique just simply referred to as OPQRST and A, as a handy way for the clinical exercise physiologist to work through a methodical way of tracking these symptoms. The O stands for onset, and it's important to understand when the symptoms began, what the patient or client was doing, how long ago from the time of the general interview did those symptoms begin. Provocation and palliation are also important considerations. And provocation refers to the pain onset, what brings on the pain and what relieves the pain. Does sitting bring on the pain, or does sitting relieve the pain? Are medications helpful for alleviating the pain when it does come on? The Q stands for the quality of the signs or symptoms, and this relates specifically to pain. So, is the pain a dull, aching, prolonged type of a symptom, or is the pain sharp in nature? That understanding can help point to some of the activities that would stress certain tissues that would bring on that pain. Understanding the region of the body, the location of the body where the pain is originating, and any radiation of the pain. So even though the major ailment may be in one part of the body, does that pain spread to other parts to the body? So it's important to identify that specific body location. The severity of the pain, oftentimes a scale from 1 to 10 is often used. But it's also important to rate the severity of the pain to the specific activities during the day that the patient or client engages in. And that is also related to the timing of the pain. When does the pain occur? Is there a particular point during the day, or is it related to a particular type of activity? And are there any other associated signs or symptoms when the patient or client feels these symptoms? So is there any swelling that accompanies the onset of these symptoms? With respect to musculoskeletal condition, are there any sounds emanating from the joints, or in other words, crepitus? So the cracks or popping that sometimes emerges with movement. On this table here, table 4.1, this table relates specifically to the different features of chest pain, and there are three basic types of discomfort, what's referred to as typical chest pain, atypical, and non-cardiac chest pain. And under these three categories, these are categorized by the quality. So with the typical feature of chest pain, some of the symptoms here include a rather heaviness or pressure in the chest that is usually located either in the middle or just slightly over towards the left. An atypical type of chest pain is one that is best characterized as either a sharp pain, a stabbing, or a tingling type of pain. And the non-cardiac is attributable to some other cause. The typical chest pain will radiate to other areas in the body, typically towards the left arm, not so much the right arm or to the neck and jaw. But we see that with atypical, there's typically no radiation, and this is not applicable with the non-cardiac type of chest pain. In terms of exacerbating or alleviating factors, typical chest pain becomes worsened with physical exertion and is relieved by resting or with nitroglycerin, which is a medication that absorbs very rapidly under the tongue. With atypical chest pain, there's no clear present or no clearly present factors as it relates to what makes it worse or when it alleviates, and it's not applicable with non-cardiac related chest pain. In table 4.2 here, there are two general classifications related to cardiovascular disability. And both types of classification, the New York Heart Association and the Canadian Cardiovascular Society, both uses 4 different classes of cardiovascular disability, with the ranging from class 1 to class 4, class 4 being the most severe, and the class 1 cardiovascular disability is the least severe. So we see here that for example, in the New York Heart Association, patients with cardiac disease but with no marked physical limitations would fall under class 1. In the Canadian Cardiovascular Society, routine daily activities do not cause angina, which is chest pain. If we contrast that with class 4, patients with cardiovascular disease are unable to carry out physical activity without discomfort, and symptoms may be present even at rest under the class 4 category under the New York Heart Association. The Canadian Cardiovascular Society would examine class 4 as the inability to carry out physical activity without discomfort. So the major points here is that the different classes is a progressive way to categorize cardiovascular disability, either through the New York Heart Association system or the Canadian Cardiovascular Society system. So this ends the first video of part 1 under Unit 3.